Hi, I'm Dan Guidera. I'm a dentist in San Diego County, and this is my E4D PlanScan video channel. Today I'm going to talk about a procedure that overcomes some of the limitations when doing large implant-supported restorations. Now, there's nothing new to dentistry in the fundamentals here. It's just that bringing these fundamentals together, the superstructure design, and then applying in-office CAD/CAM is something that I don't believe is commonly done. Now, I'm really excited about this process because I believe it expands the possibilities for in-office CAD/CAM tremendously. But I also recognize that for many of you, it won't be appealing, either because of the type of practice you have, or you're just not that interested in being hands-on. But that's the beauty of E4D CAD/CAM. It lets you be the dentist you want to be. So that in my practice, while same-day restorations are an option to our patients when it's appropriate, E4D CAD/CAM is much, much more than that. So let's see what we know we can do, and then run into the limitations and overcome them. We know we can create strong aesthetic lithium disilicate, we'll call them eMax, restorations on single teeth. We know when there is moderate alveolar loss and a low lip line, we can place an all-milled eMax restoration that satisfies the aesthetic and the functional requirements. We know in cases of moderate to severe alveolar loss and a high lip line, we can fabricate eMax restorations that not only replicate the teeth, but create a scaffold for layering pink eMax ceram. All these restorations are screwed down, cemented extraorally on stock or custom abutments, as described in the last two blogs. Now, what about a case with severe alveolar loss and a revealing lip line? A C16 block is inadequate for milling in all dimensions. A B32 may be adequate mesial distally, but its occlusal gingival dimension is inadequate, and the long mesial distal span is challenging our flexural strength. Here's the procedure I used to solve these limitations. With a pickup impression, I placed temporary abutments on the model, scanned it, and using Grow-A-Tooth, designed and then fabricated a TelioCAD provisional with Dentsply's Triad VLC acrylic added on a soft tissue model. At delivery of the provisional, I used Duralay prepared impression posts and linked them with a final Duralay mix in the mouth and took a new, more accurate pickup impression, which is mandatory when linking implants. This picture is from another case. All of this is described in the last two blogs. I then delivered the provisional and took an impression of it. Making a provisional not only allowed the patient to test drive the design and give me feedback, but it also makes it clear that there was no eMax block that could handle this design. I took some spare implant parts with Duralay and constructed a prototype superstructure and painted it white for continuity. The idea being that, one, it had two margins, one for the emerging simulated gingiva and one for the ceramic teeth. Two, the margin for the ceramic teeth was significantly occlusal to the alveolar ridge, making less demands on the occlusal gingival dimension of the milling block. Three, the superstructure supports the mesial distal flexural demands on the restoration. And four, the superstructure posts allow for individual or linked ceramic restorations. I sent this prototype with the soft tissue model to the Atlantis Superstructure Division and received this titanium superstructure, which I sandblasted with 50 micron aluminum oxide after putting more vertical cuts for mechanical retention. The cuts, I believe, were a complete waste of time and good rotary instruments. I've been preparing myself for about a year to do a case like this, talking to very knowledgeable dentists and laboratory people, and familiarizing myself with at least 4 pink acrylic composite-like systems. Although it's a bit over the top in color options, the Ivoclar Nexco kit seemed most appropriate since I'm constructing most of this between appointments at the lab bench. If you want to see a real master perform intraorally, check out Dr. Christian Coachman using a Naxcom pink composite on YouTube. I started with Ivoclar's metal primer. This is an area I need to investigate more since there are other primers that may or may not be better. I placed a separating media on the model and placed the light cured opaquer up to the anticipated level of the gingiva using the gingival crest of the existing teeth as a guide. This material is extremely opaque to where you need to apply a very thin layer or the curing light will have difficulty penetrating. I used a hand LED light followed by a light curing box for each layer. The initial bulk layer was done gingivally with Triad VLC. I applied a thin layer of SR Connect to the Triad and finished with Nexco shade G3, which had been picked chairside at provisional delivery. Placing the SR Connect may have been unnecessary since the triad air inhibited layer was still present, but these two materials are slightly different chemically, and the final result proved to be seamless. I used bridge tools to set this up as linked individual units. If later a single block didn't fit, I could reset for individual units, but this wasn't necessary. The acrylic with superstructure was scanned, the individual units were oriented and margins were marked, similar to doing a Pontic. The provisional impression was scanned under clone, and inflated tooth was used to create the final design, which went to mill. The acrylic was shaped using an acrylic burr, shofu discs, and Brasseler's composite polishers. We call these car washes in our office. They're tremendous composite and gold polishers. I characterized the ceramic with Brasseler's inverted cone diamond disc, another tremendous instrument, the donut-shaped diamond, and a fine diamond disc to create a more distinct buckle embrasure. Ivoclar discourages this, but I don't get carried away, and it's never done post-crystallization. This is a jump ahead, but the individual units were tried in the mouth. The pink portion was pipped and modified for pressure points and flossability. The ceramic was brought to the mouth as a crystallized canvas for custom staining. For aesthetic cases, I'll do some pre-appointment staining, but I don't like to get too far, because if I have to change my facial contours at try-in, it puts voids in any pre-stain, and getting back to a seamless color continuity can be like patching drywall. The occlusion was worked out, but since the provisional was mimicked, adjustments were minimal. The restoration was cemented between appointments. My cementation technique was described 2 blogs ago, so I'm only going to mention the things I did additionally in this case. The long-term weak link in this procedure is the acrylic ceramic seal, so I used Ivoclar's Monobond Etch and Prime 1 millimeter past the margins. I placed SR Connect on the occlusal of the acrylic. I used Parkel's Blue Sep wherever I didn't want the cement to stick, and I placed fresh Monobond metal primer on the titanium. Unlike my normal cementation intra and extraorally, I wiped away the excess cement with a brush. For cementation on teeth, I'm very particular as to the brand of cement and technique I use. For extraoral implant cementation, I'm not contending with moisture or MMPs, so I'll use nearly any resin cement. I added a very thin layer of Ivoclar's Tetric EvoFlow bulk fill to the margins. At this point, I'm not sure if this step was good, bad, or a waste of time. I did it with the thought of minimizing the weak link by bonding to the 1 millimeter of etched and silanated ceramic past the margin. I light cured, then light cured again with the air barrier. After rinsing, I removed flash with a sharp instrument. I'm still heavily in the learning curve of the cementation protocol. The delivery of this restoration was pretty straightforward since I mimicked a successful provisional. I was pleased to see an excellent tissue condition when I removed the provisional. Since CAD/CAM design is currently done on a static model, I refined the bite to group function on excursions, established access passages for fuzzy floss, then torqued it down. With time I may shorten the cuspid, but the contralateral cuspid is a bit long, so we'll see. A couple of other things I want to mention. If you're going to do cases like this, you'll need some extra long drivers. Also, for future cases, I won't make a prototype superstructure each time. Instead, I'll send this model as a general design guide, along with the soft tissue restorative model and a clear suck-down stent from the provisional as a placement guide. So what are the disadvantages of this procedure? Well, clearly, if lab work isn't for you or anyone in your office, then this procedure isn't for you. Also, the leakage potential of the resin ceramic interface is to be determined. This leads us to the advantages. This restorative platform is completely serviceable, both occlusally and gingivally. It's very strong, and I have complete control over my product. There's no back and forth between labs, and there's no laboratory appointments for custom anything. Miscommunication is eliminated. As far as cost, the major expense is the superstructure, around $600 in this case. Otherwise, it's an office CAD/CAM, so you decide how you want to charge for it. There's a final benefit here that's not obvious. When you get more involved in fabrication, you see the possibilities and the pitfalls. In short, you learn to innovate and sharpen your skills. After all, there's no lab to blame. So after 5 years and nearly 1,500 CAD/CAM cases, I'm not the dentist I used to be. And at nearly 63 years old, I love what I'm doing more than ever. So I hope there's something I've told you today that you find beneficial. Next time I'd like to talk about failures. So until next time, I hope you thrive in your practice.